Hi, my name is Anya Samek. I'm a associate professor at the Rady School of Management at UCSD, and today I'm joined by Judd Kessler, who's a professor at Wharton and the author of a recent book that just came out. If we could see it here, it's called Lucky by Design. It's directly behind him as well as in my hands. So it's February 12th, 2026. I'm excited to talk about the book and talk about market design. Welcome, Judd.
Thanks so much for having me. Happy to be here.
And so let's get started. I want to talk to you a bit about market design and some of your research in that area. The book is on market design. What is market design and what is your book all about?
Yeah, so market design is a subfield of economics, just like behavioral economics is. But the focus of market design, at least the focus of where my research is and what the book is about, is markets that allocate things without relying exclusively on prices. So this is often called like matching markets and in the literature, but it's essentially recognizing that sometimes we're doing allocations and price is not doing all of the work or maybe not involved at all. And so, I'm an economist. I've been teaching at Wharton for 15 years. I teach econ classes, including behavioral econ. And even in my behavioral econ class, most of what we do is think about supply and demand curves and, supply and demand curves crossing and finding an equilibrium point. And when we do that, when we say like supply equals demand, we're making an assertion that prices will adjust to decide who gets what. Market design in my book thinks about the cases where that is not what happens. And so the book covers examples ranging from uh, getting reservations at hot restaurants where there, might be really hard to get a reservation, but they don't raise the price, getting tickets to live events, either sporting events or uh, musical or band performances or theater performances where the ticket price, the face value of the ticket price is kind of too low to satisfy demand from all the people who want to see it. And you end up needing to allocate tickets to Taylor Swift's Eras tour in some other way. It's not just, oh, I want to buy the $49 ticket and I can just go do that. And then there's a whole slew of markets where we don't have prices at all. So if the government is giving away benefits like spots in desirable public elementary schools or library books or other things that they want to give away for free, right, the price is not going to be involved. They need to decide. And one of the ones that I've done a lot of research on, I think we'll talk more about, is organ allocation. Because this is a case where we have decided as a society that we do not want life-saving organ transplants to just be sold to whoever has the most money. We want to allocate them in a way that might be fairer or might kind of make better use of those organs because it is possible that the folks who are willing to pay the most don't necessarily get the most additional life years out of those organs. But also, we might think it's fundamentally kind of wrong to let the rich be the only ones who get life-saving treatments and not make those available to the poor. And so, as a result, one of the kind of key areas that I've worked in is how do organs get allocated and how can we design those allocation systems to be better and fulfill the desires that we have as a society to be equitable across the population.
So one of the reasons we may not always use price mechanisms for allocating resources or in markets is due to this equity idea. So is this also applied to the Taylor Swift tour then? We didn't want to have $100,000 tickets?
Yeah, so I talk a lot in the book about why we have. So I call these hidden markets, these markets where price is not doing all of the work, where some other set of market rules that's deciding who gets what. And the reason that hidden markets arise, it's a mix. Sometimes it's the government and it's, an equity reason. Sometimes it's a private seller or, when Taylor Swift's pricing her tickets, it might be her production team, the venues that she's at, we're kind of working together to pick prices. And when it's private sellers, I think there's a mix of reasons. So some of it, when you think about the restaurant, the hot restaurant that has a line around the block, like they might be doing it strategically so that they can bolster future demand.
Hmm.
So they keep prices artificially low. They got the line around the block, and then people who walk by because of social information or social proof or kind of a herding phenomenon. And they see that this restaurant has a line around the block and they think, oh, it must be really good. Maybe I'll try it. Maybe not tonight because the line is so long, but maybe I'll come back next week or next month. And so that might be a strategic decision that the firm makes in order to support future demand by keeping prices low. We see this a lot, I think, with fad products. Like this past summer, it was Labubus, the like ugly, cute little dolls that people were wearing on their bags. But I'm old enough that I remember Beanie Babies and Cabbage Patch dolls, where part of what makes everybody want to go out and get the product is that it is notoriously hard to get. And so that drives future demand. I don't think that's why Taylor Swift keeps prices low. Like, I don't think she needs to bolster future demand. We know who she is and kind of that she's going to be a good live performer. I think they're her equity concerns, her concerns about wanting her fans to be able to access her show, even if they don't make that can spend all. And then, maybe also it would not be a good look if she's charging, thousands of dollars to fans who don't make that much in a month to see her show.
And the kind of one thing I've thought of as you're talking, where this comes up as well, is if there's a disaster and then Uber starts charging sky high prices for rides, there's a public backlash. So it's there's a perception that you're taking advantage of customers as well.
Yeah, yeah, and I think in Taylor Swift's case, right, she's a billionaire, and I think that changes even though she's a person, unlike Uber might as a platform and
Shoot.
emotional reaction to that might punish her more in the future, and so she might not want to, particularly not want to have that perception.
That makes sense. And in particular, in the organ allocation example, which is what we're going to be talking about today, there's all sorts of ethical reasons why you wouldn't want to sell organs. And so let's talk about that. So how are organs allocated now? Like what is the market?
Yeah, so this is the fun thing about, or one of the fun things about market design and what happens when you don't use prices, because every market that we just talked about a bunch of different markets, and they all have different sets of rules about how you access the scarce resource, how you can be the one to actually get access to it. And so, I do this in the book, but it's you could imagine going through the different sets of market rules and thinking, how well are these doing on equity? How well are they doing on efficiency, getting people the things that they want? And how easy are these rules for market participants who you might be participating in that? I call this the three E's in my book: the equity, efficiency, and ease for market participants. So just to be concrete about it, right? One way that you access stuff is a first come, first serve line where you have to literally stand there, and that's not easy because you might be there for hours waiting for your turn. There's rules where it's first come, first serve, but it's a race. Whoever kind of clicks the fastest when the Taylor Swift tickets become available might get it. When I was in London for a conference last summer, there was a lottery at Harrods for their limited edition Labubu dolls, and so you put your name in and hope that you were randomly selected to be the winner. And so there's different allocation rules that get used. Market designers, academic market designers, spend a lot of time building centralized clearinghouses where, I rank my preferences over schools to send my kids to, and I have a priority at each of the schools, and other parents have priorities, and our preferences and priorities get combined, and an algorithm runs. And my advisor, Alvin Roth, who won a Nobel Prize in part for this kind of work, right, have been helpful in designing these kinds of mechanisms in various contexts. Organ allocation is one that is a centralized process, but kind of we can think of it most easily in terms of a waiting list. So it's first come, first serve to a certain extent in something like kidney allocation, where one of the things that is going to matter in whether you are allocated a life-saving kidney transplant is how long you have been on dialysis, which is the treatment that you get if your kidneys stop functioning. And you can be alive for many years, thankfully, on dialysis, but it's not pleasant. You have to go into a dialysis center typically a couple of days a week for multiple hours. It's painful treatment. So really disruptive to one's life. And so one of the considerations, along with things like, you know, uh, how um, how healthy you are at the moment, like if you're kind of in worse shape, we prioritize giving you organs sooner to kind of prevent imminent death. Uh, how close you are to the organ that has become available. So if there's a donor organ that becomes available, can it easily get to you without having to be on ice for too long? Right? There's a bunch of considerations that come into play, but then how long you've been waiting on dialysis is one of the considerations. So I should pause and say I'm describing how we allocate deceased donor organs. So this is, organs that are made available when people die and are willing to let their organs be donated to other people to save their lives. Um, and I should also clarify that I'm talking right now specifically about kidneys, which rely quite a bit on the amount of time you've been on dialysis because that is a treatment that is available. There are other organs where the rules are different because there is no dialysis for liver. Your liver function kind of starts to fail, and then at some point you either need a liver transplant or that's it. And so those organs kind of rely more heavily on your medical need because there is no equivalent kind of waiting period.
And this is also specific to the US, I imagine. Or is this very,
Yes. So I'm describing the US system. I think most systems kind of rely on some of the same criteria, right? Like some human biology is a component, right? I can't receive an organ that's not medically compatible based on my blood type or other considerations. So the kind of the way I like to think about it is like a complex mix of things, but then when we are kind of among all the people who might be eligible for this one particular organ that becomes available, right, one of the key considerations is going to be how long have you been waiting? Another one is going to be how far away are you from the organ when it becomes available? Because we recognize that if we have to bring the organ across the country, that might be less it might be less viable for you. That it's degrading outside of its donor body.
and so what
So
are the strategies people use in these markets to try to get in line first or
yeah, so I talk about this a little bit in the book, but this is like state of play now, and then a lot of the kind of thinking and work that I've done is about how to improve the systems beyond this. But just to get a sense of, okay, for when I wrote the book, one of the promises of the book is if you understand the markets, you can play certain strategies that help you succeed in those markets. And so one of the things that I did was for each of the market rules, like what are the strategies that people are playing once they kind of understand the state of play. And with organs, the way I just described it, it's how long have you been waiting and how far are you from the organ that becomes available. And so the strategies that kind of get played by people who can play them are what we call multi-listing. So being on multiple wait lists at the same time. And the way that folks do that is by listing themselves as a potential recipient at multiple transplant centers. So I live in New York. If I needed an organ, I would register at the transplant center in New York. But if I can satisfy the criteria of a transplant center in another region or another state, which might be things like, do I have a residence that is nearby that I can list as a residence for the purposes of being at that transplant center, say because they want to know that I'm going to recuperate somewhere near the hospital so I can get back there if I have any complications, right? Like, do I have a place that I can list as a residence there? And then also, can I get there within a certain number of hours? Because if an organ becomes available, then they're going to say, hey, we're going to do the transplant, but we need you here, in 4 hours to do it. And I need to be able to say, yes, I can. Now, this is where the equity concerns come back into play because folks with more financial resources often can meet those criteria in a way that maybe regular folks have a harder time doing so. Um, in the book, I talk about Steve Jobs, who needed a liver transplant at some point, and who famously lived in California, but received his liver in Tennessee. And again, I don't know if he actually did the multi-listing, but you could see that he lived in California, but could satisfy all the conditions for receiving an organ in Tennessee, where the waiting list for livers was much shorter than in California at the time. Like there was, more organs became available for folks who needed them, and so the wait time to receive a liver when you needed one was shorter than in California. And I should say more organs per recipient, potential recipient. And so he, bought a house, I think, in Nashville that he could recuperate at if, after his surgery. He could fly to the transplant center on his private jet at a moment's notice, right? And so these are the things that he's able to do. And we might, I think nobody begrudges somebody doing whatever it takes to save their own lives, but we could say we look at the system and say we think we could do better.
So we consider this kind of gaming a failure of the market, considering it's set up to specifically, make it fair regardless of income.
Yeah, I think of this as gaming that we might be problematic, but I mean at the same time, right? If you were going to take the other side of the argument, you'd say, well, wait a second, isn't it unfair that the wait time in California for a liver is, many months longer than the wait time in Tennessee? Like maybe to the extent
Exactly.
that Jobs is doing something or did something that was harmful to folks in Tennessee, like he's also doing something that's helpful to folks in California because, maybe he's shortening the wait time there. So again, it's in the end, it's a fundamental issue of we don't have enough of this scarce resource, the scarce resource here being the life-saving organ transplants.
Hmm.
And so that is the fundamental issue. We have decided not to just give them to the rich. We might not like when rich people can kind of take extra advantage of the system. But a key question is like, can we get more organs to make the scarce resource less scarce? And that's what a lot of the research that I've done in this area has been focused on.
So what do you suggest? What's the solution? How can we improve this market?
So, so this is a key question, and I should say, for those who um, uh, you do this long enough, and you kind of realize that like because there's so much kind of kidney failure and other medical issues, like eventually, I feel like everybody ends up knowing someone or knowing someone who knows someone who is needs an organ or is an organ recipient. So, I think this is a pressing issue for everyone. But let me also add, if it has not yet been a pressing issue for anyone listening, that it's a major kind of problem in the US that we have and around the world, but in the US in particular, that we have so many people who are waiting for life-saving organ transplant. So, and I'll tell you how I'm trying to solve it, but first, why? Like, in addition to kind of people having to wait on dialysis, we have like 10,000 people or more who die each year while waiting on the organ donor list. We have probably an equal number or more who are not on the waiting list when they die, but become too sick to transplant, so they get removed from the list, and presumably they die kind of while not on the list anymore. And it's a major kind of mortality cause in the U.S. It's also a massive financial cost. So the US, in particular, Medicare, pays for dialysis treatment, treatment for end-stage renal disease, kidney failure, for basically everybody. After, private insurance covers it for a little bit, and then Medicare takes over. And it's a very expensive treatment in addition to being time intensive and painful for the patient. And so the kind of rough estimate is that the US spends 1% of the federal budget on treating end stage renal disease. So it's like 1 cent of every dollar that the government is spending is going to be on this particular issue. So if you can get people organs, you're going to save lives, you're going to extend lives, you're going to make people have to spend less time on dialysis, and you're going to save the government a lot of money. So how can we do that? Well, there's a few channels. So the kind of I was describing how deceased donor organs are allocated to folks. Deceased donor organs come from individuals who have died in a way that makes their organs available for transplant. So people who die, otherwise healthy. So you can think of car accidents, motorcycle accidents, kind of other causes of death that are, that don't involve your organs deteriorating. Because many causes of death, the body breaks down in ways that makes the organs, no longer viable. But if the organs are viable, then folks who have either agreed in advance to be organ donors, so you can think about this as when you go to the DMV and you get your driver's license and there's a question on it that says on the form that says, would you like to be an organ donor? Folks who say yes on a question like that or sign up in some other way, they're agreeing to be organ donors if they die in a way that makes their organs available for transplant. And those organs almost always get recovered. So the transplant doctor will learn that a person who's just died is eligible for transplant, and they'll inform the family that the person's an organ donor and transplant the organs. And then the other way is for folks who have not signed up, you can ask next of kin. And that's a little bit of a harder conversation because the next of kin have obviously just lost someone close to them, maybe in a way that was kind of a tragic accident. And so that's not as many of those get recovered, but about half of those get recovered. That's at least best estimates that I know of. So you're going to ask a next of kin, hey, sorry for your loss. Let's try to find a silver lining and uh, help save other people's lives as a result of this tragic accident. So the question is, can you create more people who are willing to be donors, either saying yes at the DMV or wherever else they get asked, or get next of kin to agree to donation when it comes up. So there's two sets of research that I've worked on. One I think is more promising than the other. So the promising one is trying to create some kind of incentive for folks to register as organ donors when they are young and healthy and alive. And this is something that we do not do in the US, but other countries do. So China, Chile, Israel, and Singapore have give people kind of a extra incentive to register. And when I say incentive, I'm not talking about financial incentives because we might not like those for moral or ethical reasons, just like we don't like paying people for having people pay for the organs. We might want to keep money out of it entirely. But the incentive instead is priority on organ allocation waiting lists for folks who have agreed to donate in the past. So you're young and healthy. You could either say, yes, I would be a donor if it came up, or no, I don't want to be a donor if it came up. But if you say, yes, I'll be a donor, then if later on, instead of being a donor, you end up needing to be a recipient, we're going to treat you better. We're going to kind of elevate you on the waiting list relative to folks who were not willing to contribute. And so this kind of uses the allocation rules as a way of building in an incentive, a reason for folks to do the generous thing at the start. And this is work that I've done with Al Roth. We did it experimentally in a laboratory where we didn't have real organs, but kind of we modeled the game, the decision of whether to say yes or no to do a charitable act, and whether you got some benefit from that if you ended up needing charity to help you rather than being in a position to give. And we found that, the underlying mechanism of giving priority for this scarce resource, like you can generate a lot of extra contributions on the front end. And then in addition, we did research evaluating the rollout of this program in Israel because we had data from their period before and after the change. And we saw a few things, including that when this policy was announced, you saw a big increase in the number of people who signed up to be organ donors, that like it actually was generating more donations. We also, in Israel, the policy also gave incentives for the next of kin. So folks who had not signed up, if the next of kin consented to donation, the whole family got put on a higher priority level than if they had not said yes. And so that change also led to an increase in the likelihood that people said yes as the next of kin when somebody who was not registered as a donor passed away.
So what
So
do these numbers look like, if you remember from your paper, before and after
yeah,
the rollout in Israel?
yeah. So we looked at the number of new registrations that happened. So the way they rolled it out in Israel, this getting a little bit into the weeds, but I think is interesting and helpful for folks thinking about policy design. They were introducing this in Israel, and they basically said, look, there's two groups of people. There's folks who are not yet 18. For them, we can say, look, when you get to be 18, you're going to be asked this question, when you get your driver's license for the first time. And so if you are not yet 18, like, as a kid, you get priority for organs anyway. When you get to 18, we're going to look at what choice, you make at that point and either give you priority or not. What if you have not what if you're over 18, or what if at 18 you say no, but then later you change your mind? Well, they have an issue, which is they can't give priority to folks who signed a donor card yesterday because then I can just wait to find out that I need an organ. Once I find out I need an organ, I go sign the donor card because of course I want to have priority, but I'm never in a position to give.
This is
That would
like
be
the open enrollment periods in health insurance. So you can't just let people wait to get health insurance when they get sick.
exactly, exactly. So that would introduce a loophole that would be really problematic. And so what they said was we're going to have a 3-year delay. So if you sign when you're 18 and you end up needing an organ when you're 19, that's fine. You'll have priority. But if are 40 and you sign today, it's not until you're 43 that you're going to be eligible for priority. And so that 3-year delay is going to kind of mean that it's too late if you wait until you end up needing an organ to sign the donor card. So that was the policy. And then they said, okay, we're going to let everyone who, we're introducing this policy. We need people that have a chance to sign up. And then we need a deadline where the 3-year rule will kick in. And so what we did was we said, all right, if anyone who signs, between now and that deadline, they're going to get priority starting today. If you wait until after the deadline, then the 3-year kind of delay is going to kick in. And so we asked, how many additional signatures do you get in the months leading up to that deadline? And so this is like a kind of a lower bound of how many more donors are you going to get overall, because this is like looking at everyone in Israel who's not yet a donor, who's aware of this policy change in this window. And it looked like we got about 100,000 extra donors in the period, about a year worth of time when they were kind of advertising this new policy change. 100,000 is a lot in a country the size of Israel. Um, so, but again, I think that was like the stock of people who are not yet donors. We have not yet, but one could imagine because the change was 2011. You could go back and ask, okay, what's the rate at which 18-year-olds sign the donor cards over the last 15 years? relative to the 15 years before. That would be an interesting analysis we have not yet done. And then the other thing is we could look at the next of kin and what do they say? Now those estimates are a little noisier because the country is small, not that many people are dying who are not registered, and the next of kin has to decide. But my memory is that it was about 50% of folks saying yes before, and it went up to like 60 or 65% of folks saying yes when the family was going to get priority on the waiting list. So you're getting like a 20 to 25% increase on the base um, of folks who've agreed to be donors.
Another thing that's really interesting about that is the policy was enacted in 2011. There's been a shift in enrollments. And then how does that actually affect the culture of being an organ donor? So I'd imagine if the majority are now organ donors, even if there was not the priority, this would kind of be the default. Like now this seems like what I should do because of social norms. I talk about social norms a lot. So
Yeah, so that I kind of wish we knew more about whether to what extent it's the social norm that's changing versus the incentive that's changing. Because I think in this particular case, it's both. It's knowing that, the normative thing is to be a donor. Maybe the kind of descriptive norm of most people are becoming donors now. Like maybe all of that is having an additional effect beyond the I'd like to have priority if I ever need an organ.
I mean, the other part that could push against that is if you spent a couple years advertising being an organ donor heavily, and then drop that off and just had the policy kind of continue
Yeah.
forward, you could see also a decline compared to the.
Yeah, I mean, one thing that we got a big time series of kind of number of registrations in each month in Israel for many years, including the window when they announced the change. And one of the things was that we saw was that the priority policy made it such that the campaigns that they ran were more effective. So when they were doing campaigns in the pre-period, like a bunch of people would sign up. But when they were doing campaigns during this window, like they were drawing attention to it and they were saying, hey, there's this extra benefit. So you got extra bang for your buck on the campaigns you were doing, which hopefully means that they're, continually doing campaigns as opposed to kind of dropping, thinking it's sufficient to just, have the priority policy in place.
So you would advocate for a similar policy in the US as prioritizing organ donors for organs. Do you have a sense of why we don't have this or what the barriers might be?
Um, I it frustrates me that we don't have this. I think probably folks' attitude is that we have bigger fish to fry in terms of like more immediate policy changes. So the way that policy discussions about organs have rolled out recently are kind of about the organizations that are the organ procurement organizations, the actual nonprofit entities that operate in each of the regions that are asking the next of kin to be organ donors that are doing helping to facilitate all the transplants and kind of finding the donors and monitoring the recipients and the waiting lists. Like some of those organizations are performing very badly relative to their neighboring organizations. And so I think a lot of the push recently has been, you know, can we improve the failing institutions, the overall organization that oversees the smaller organ procurement organizations, like the parent company, are they doing what they're supposed to be doing? So a lot of the pushes have been kind of not about how to change the allocation rule, but about given an allocation rule, can we be like doing a better job of actually delivering what we're supposed to be delivering? So I think that's my understanding of why kind of attention is not on the allocation rule itself.
Okay, so no real barrier, just kind of an overwhelm of other.
That's my read of it. Like I don't I we often worry about is it like legal to give incentives for organ
Mhm.
donation. We don't allow people to be paid to be organ donors. But this is one of these areas that's like not, there's no money changing hands. And I think if you ask people, is it fair or appropriate? I think they would say like, yes, we should prioritize people who are willing to
Yeah.
contribute, right? And this is when COVID hit, we said, of course, we're going to prioritize, healthcare workers who need medical care. If like there's one hospital bed left, you're going to give it to the nurse who's been treating people on the front lines who got COVID that way because that seems fair, and also that like makes COVID care more available for everybody because that nurse goes back to work, and other nurses and doctors feel safe working knowing that they're going to be prioritized. Like, you ask people in surveys, they're very supportive of that. And so that same logic, I think, would carry the day with a policy like this.
And it seems like you could do a pretty simple welfare analysis to look at how many more organ donors we might have in the US if we adopted the Israel policy using their numbers and then try to figure out what that looks like for lives lost, a reduction in lives lost. Seems like a easy exercise. I don't know if you've done that.
Haven't done that directly with that data, but have kind of made that argument in a more kind of qualitative way of basically
Right.
like this is, the organ procurement organizations that are not recovering enough organs, the ones that are being labeled as needing to improve. I mean, this priority policy would just make everybody's lives easier. It doesn't mean that those organizations shouldn't also improve on other dimensions, but here's a, change that like that could improve outcomes across the board. Feels like something we should be leaning into.
Well, thank you. I appreciate your time. This has been a really insightful look into market design and organ allocation. Thank you,
Thanks
Judd.
for having me. Thanks for having me. This was fun.